Hello, I am Dr. Kyoung-won. This is the case discussion to share clinical difficulties and find the best treatment. We have three doctors, Dr. Kim Kyoung-won, Dr. Kim Ki-Seong, and Dr. Kim Yeong-taek. Hello. For the dental TV viewers on the dental site, on the right-hand side of the video player, there is a real-time chatting window for you to post questions to us or share comments. Let's look at the case to be discussed. The patient is a 66-year-old female with hypertension, diabetes, PDCA with stent insertion. If you look at the story, the patient came to me last year for prosthesis. The residual roots of 12, 16, and 22 were extracted. After that, she didn't come back, and recently she wants to receive the treatment. In the edentulous region, the alveolar ridge atrophy is observed. There is a lack of space for prosthesis in the interior region. What will be the best way for prosthesis treatment by creating vertical space? It looks like before and after the extraction, the patient has neglected the treatment. If it was treated earlier, it would have been better. What do you think, doctors? The occlusion is collapsed and the vertical dimension is lost. I'm not sure. Dr. Kim Ki-seong is a prosthodontist, so he can help us. I can talk about the prosthodontics, but she has systemic diseases. If that is addressed, I can suggest some solutions, but this is challenging. The bone is resorbed. If you look at the mandible, I don't think there is a big problem in placing fixed type of prosthesis by placing implants, but there is a vertical dimension problem. Now we have different periodontal and prosthodontal departments, so if a prosthodontist resolve some of the problems, we can address the rest. She has various systemic diseases. My colleague doctors, senior junior doctors, ask me questions regarding that because I am with the big general hospital, so I will think about that through this case. The audience, please think about what your approach will be by listening to this. If you have any good ideas, please share that on the real-time chatting window. So let's have a look at how the doctors approach this. Dr. Kim Yeong-taek. Implant positions have been thought about. Number 3 and 4, the fixed prosthesis can be delivered in quadrant 1. Number 2 is very narrow, so Pontic can be used there. So a 5-unit implant. Implants can be placed on the mandible, matching maxilla, so up to number 6. Number 2 is most challenging. If I were to make the whole left side that can be splinted, it can be placed as a single tooth. At one time, placing one implant per tooth was a rule, but now a fewer number of implants can be used to support larger number of prostheses without a problem. It's better in terms of the peri-implantitis. It's hard to place an implant in narrow space, but maybe number 22, maybe I have to place an implant. Precondition for that is the vertical dimension should be adjusted first. I need to consult with the prosthodontist. Therefore, today I am going to rely on Dr. Kim Ki-seong. for this. But as I said at the beginning, the patient has so many systemic disease, including hypertension, DM, and she has a history of stent. And do I need to treat this, or do I need to send her to general hospital? These days, we have so many senior patients. Therefore, I need to understand my limitations in treating patients. So based on my criteria working in a general hospital, let me explain like this. And I will also explain some guidelines. If the patient is on an anticoagulant, can we just treat them? Depending on the type of anticoagulant, it could be different. However, if the patient has a history of stent, I think we need to consult with the medical doctor. If the patient has been monitored for a long time by ourselves, we can skip that part, but we need to ask the medical doctor whether we can stop the medication. Not only that, renal failure, liver disease, hematological malignancy, these are the bleeding risks. Therefore, we need to take the history of those. Most importantly, we need to get all the information from the patients. Sometimes patients know the answer. They say, I can stop the medication, but I need to take the antibiotics before surgery. Still, you need to ask the medical doctor. Anticoagulants, aspirin, Plavix, or NOACs, the novel medication. I have not seen patients on NOAC that much. We don't need to know all of them. We can just refer to the result of the consultation. We just need to know warfarin, aspirin, or Plavix. Guidelines of ADA, warfarin or Plavix or aspirin are taken by patients who have experienced a deep vein thrombosis or embolism. So they need to be on the medication. That is the guideline. But there is an increased bleeding risk, which may put the patient in danger. Aspirin, we have consensus on aspirin. We don't have to stop them. After stent surgery, single or dual drugs of aspirin is given for a year. We shouldn't arbitrarily stop the medication, and you can keep the patient on the medication or get a consultation from a medical doctor. Warfarin is controversial. Neurology says a patient should be continuously on this medication to prevent stroke, because the life of a patient is more important. As surgeons say, INR needs to be measured, and we need to identify the situation of the patient. The patient would know about them. I asked an oral surgeon in our hospital, and he said that there's no need to stop warfarin in general. And he said, as much as possible, the patient should be continuously on warfarin. If they say we can stop it, then we need to follow it. We don't need to be too much worried about the patient on warfarin. Like before, NOAC is very good compared to the conventional agents. According to the recommendation, that doesn't need to be stopped for small surgeries. So anticoagulants can be used while we treat them. However, we need to get the consultation from a medical doctor. And there was a Korean study And the recommendation is we need to minimize the treatment under the medication, like extracting one tooth only, etc. So that's the recommendation. Risk assessment of bleeding. Some are classified. So if it doesn't cause bleeding, it would not be a problem. If it causes bleeding, we need to avoid them. What is important is we need to identify what drugs the patient is on, and aspirin can be used for implant placement. Personally, I haven't experienced any problems with that. And if there is inflammation, that should be controlled before the treatment can be provided. Another disease, DM, I believe you already know about that. No dentists seem to know exactly what uncontrolled DM means. People say the patient says the figure is 200. Is it okay to treat the patient or not? Criteria for diagnosis: normal, prediabetes, and diabetes. We don't diagnose them, so we don't need to be concerned about that. But roughly, we need to understand that DM is under control if HbA 6.5 to 7. And if you can read the chart, it will be good. Fasting plasma level less than 130 milligram 2 hours after meal. The figure should be less than 180. Uncontrolled DM means normal level less than 70 or bigger than 200 milligram. Patients know if they say they are not controlled, we should not proceed with surgery. If the surgery involves bleeding, we need to avoid that. And these are not absolute numbers. Even though the glucose level is 156, you can go ahead. If the patient is on diabetes medication, if it is controlled, you can give a standard treatment. When the inflammation is under control, it helps the treatment. As for the uncontrolled DM, you need to communicate with the patient with the numbers so that you identify whether DM is under control or not. When we talk about this, the systemic diseases, the story can get long, but I tried to make it brief, but it got prolonged. I talked about this with Dr. Kyoung-won. Dr. Kyoung-won doesn't agree with me on some of the points. I want to hear his opinion. I am with the university hospital. I see many diabetes patients and stent patients. Stent is covered by the National Health Insurance. And there are many patients who have a stent in the coronary artery, and many patients are on antiplatelets and anticoagulants, as Dr. Yeong-taek talked about it, but let me clarify the terms. PTCA is the name of the disease of the patient in the case under discussion. PTCA with the stent insertion. PTCA stands for percutaneous transluminal coronary angioplasty. Through skin, percutaneous, an endoscope is inserted to the coronary artery, which is at the heart. Catheter is inserted to the coronary artery to expand it using a balloon or stent. And if you insert a stent, PTCA with stent insertion is the correct term. PTCA, percutaneous transluminal coronary angioplasty, usually that is performed going through the femoral artery. Radial or ulnar artery can be used as well to go to the heart. Another thing, PCI stands for percutaneous coronary intervention. To be specific, PCI is more broader in concept than PTCA. using a balloon or stent can be inserted for the intervention. Today, drug-eluting stent became available, which is more advanced stent implantation, and a coronary atherectomy is also under PCI. One more thing, internist or thoracic surgeons talk about CABG, CABG, which stands for coronary artery bypass graft. PTCA or PCI uses catheter inserted through femoral artery, whereas CABG is an open heart surgery. Saphenous vein is taken from a leg and grafted. Compared to PCI, when percutaneous approach doesn't work, CABG is performed. So that was the clarification of terms. Let's talk about the hemostasis mechanism, which you learned in the dental school. I brought up a diagram. When blood vessel is damaged, to put it simply, the first action that occurs is the vessel constriction. The vessel is constricted. Artery or arteriole has a smooth muscles. When the vessel is cut, the vessel constricts and moves on to the coagulation phase. So vasoconstriction is very important. When vein is cut, the blood drips more. After that phase, platelets get aggregated, forming platelet plug. Up to there, it's called the primary hemostasis. Coagulation cascade happens next. That's the coagulation mechanism. Thrombin is generated, leading to fibrin and the blood clots. When we talk about a blood coagulation test, the most basic tests include 3: blood test and CBC. The bleeding test is testing the function of platelets. Using a lancet, a small cut is made in the air to do the bleeding test to check the function of the platelets. CBC is the blood cell count, number of platelets. Normally, it should range 150 to 400,000. When the platelet numbers less than 100,000, hemostasis cannot occur properly, leading to pancytopenia or thrombocytopenia. PT and APTT, prothrombin time. When I was a resident, I shook the blood, measuring the time in an emergency room. So these days, we use INR, the ratio. So PT and APTT are related to the coagulation. When we talk about anticoagulants, there are antiplatelet drugs, including aspirin or Plavix, clopidogrel, as Dr. Yeong-taek said. That has to do the primary hemostasis. Next, anticoagulants, such as warfarin or Coumadin. So you need to understand anticoagulants are different from antiplatelets. Vitamin K is the antagonist for warfarin, as Dr. Yeong-taek said toward the end. NOAC, novel oral coagulant agent. In short, NOAC, that's a new drug warfarin should be monitored with INR, PT, but warfarin can be monitored quite easily, so that is why it is used widely these days. But still, the conventional drug is warfarin. Some of warfarin can be replaced by NOAC, not all of them. NOAC can be stopped for a short period of time. If a patient will receive surgery today who is on NOAC, if the patient comes without morning dosage, the blood control can be made much easier. So warfarin is different from NOAC. Sometimes dentists get confused over thrombolytic agents, such as urokinase or streptokinase. That's different agent. So you need to identify whether the patient is on antiplatelet such as aspirin or clopidogrel or anticoagulants, warfarin or NOAC. You need to differentiate them. So recently, we have many senior patients, therefore they say we should not stop medication. I went to Asan Hospital homepage, pediatric cardiology department. So it says here, warfarin dosage should vary from patient to patient. The warfarin is the same, but anticoagulation mechanism can be different from patient to patient. Therefore, INR should be measured, should be monitored. In general, in the internal medicine or thoracic surgery, INR is recommended to be 2 to 2.7. 2.5 to 3.5 range is also used for the control. Here, this is the information from the pediatric cardiology. Antipyretic, analgesic, ibuprofen can cause problems in patients on warfarin. Anticoagulants, hemostasis can be a problem, so we shouldn't use NSAID, but acetaminophen, antipyretic, analgesic should be used. Tylenol, acetaminophen should be used. For a dental treatment where bleeding is expected, the medication should be stopped for 3 to 4 days. It is written here for children. But we have many senior patients, just like in the internal medicine. We need to be very careful when bleeding occurs during extraction. For simple extraction, we need to apply pressure on the site so that bleeding can be stopped. And we also should suture the site. As Dr. Kim Yeong-taek said before, the oral surgeon in Ilsan Hospital, he is referring to the hemostasis process during surgery by performing the surgery very meticulously. Here it talks about the prevention of endocarditis. In the past, amoxicillin was given, and recently the medication is given 1 hour prior. Regarding antibiotics to prevent endocarditis, you can refer to the information here. Diabetes was explained very well by Dr. Kim Yeong-taek, but let me show you just one slide. We pay attention to the fasting blood sugar. We pay attention to that only. If it is below 150, I don't really be worried about that. So DM can be considered under control. But what I want to say is that we need to pay attention to HbA1c, which was briefly mentioned before. Dentists tend to ignore this value, but this is checked by internists always. HbA1c is the glycated hemoglobin in red blood cells. The red blood cells live in the blood for 2 to 3 months. So if this figure is not good, the blood sugar control is not properly done. It should be 4 to 6% normal, and for diabetic, it should be maintained below 6.5 to 7%. Even though the fasting blood sugar is low, if this is not controlled, that means blood sugar in normal day-to-day life is not controlled pretty well. So HbA1c should be checked. Blood test is important when a patient comes, whether the sugar level has been controlled for the last 2 to 3 months. We need to check HbA1c. If the number is okay, you'll be able to treat the patient without problems. I gave a rather lengthy explanation, but I hope it helps. For conscious sedation endoscope in GI, do they stop aspirin? Yes, aspirin should be stopped. Bleeding in GI is a major problem, so they stop the aspirin medication. When it comes to dental treatment, recently aspirin, as Dr. Kim Yeong-taek said, aspirin can be kept. If you take just aspirin, the patient says it can be stopped or continued because internist says that to patients. But aspirin is taken with the chlorpidogrel together. If both of them are not stopped, platelets are not formed, so early hemostasis cannot be performed. If you press gauze on the site hard, once coagulation occurs, coagulation phase kicks in, it will be okay. So for patients with both medication, aspirin can be kept, but chlorpidogrel should be stopped for 4 to 5 days. When warfarin is not stopped, when you extract the tooth, you need to pay extra attention to hemostasis. Otherwise, the patient comes back to you the next day and says, I bled a bucket full of blood. In a university hospital, it goes like this. If an internist says warfarin cannot be stopped, the patient is hospitalized. It is bridged to heparin for a short-term control during extraction of a tooth, and the patient is put back on warfarin after it. We have to be conservative, and we have to do extraction very meticulously to reduce the risk of bleeding. When a patient comes to a private practitioner, I didn't know NOAC is the word instead of NOAC. Can the patient treated after a day of discontinuation of NOAC? Of course, after consultation. And warfarin should be discontinued, right? INR is important when it comes to warfarin. Usually, that should be discontinued for 3 to 5 days. INR should be checked, but private practitioner cannot do that. In a university hospital, I extract after checking INR. So in general, if it is below 1.2, it's okay. But if it is below 1.5, it's good. As you said, if you look at the paper from Ilsan Hospital, there was a study of 3 groups, discontinued group, continued group, and the group switched to heparin. But if you look at INR, it's very low too. That's why the group on the medication continuously didn't have a lot of bleeding. And the meticulous extraction contributed to hemostasis. For a private practitioner, I believe it's not easy to treat the patient on warfarin. If a patient should continue warfarin, I would refer the patient. Private practitioners get nervous when bleeding happens rather than pain. So we are afraid of bleeding. In my view, ER is in each hospital. You need to identify where ER is. I'm supposed not to tell this. The interns in ER would not like this. In our hospital, we have ER at the backup. So we extract when the patient is on warfarin and the patients are referred to us. So I don't really worry about extracting teeth. When I make an incision, I get the feel, and when it bleeds, I'm a little bit afraid. Recently, as you said before, we have many senior patients. The internal medicine also say if the medication is discontinued, a life-threatening accident can occur. So they recommend the continuation of the medication. If the patient has poor condition, including serious inflammation, I make the patient hospitalized and switch to heparin. Patients are very worried if the internal medicine says the medication should not be discontinued. So you need to consult with the internist for the matter. The case under discussion is about the patient with systemic diseases. Let's go back to the case under discussion. Dr. Kim Ki-Seong, would you make the final comment on that? Let's talk about the second option, focusing on prosthodontic treatment. The patient's vertical dimension is lowered. The vertical dimension of occlusion means when the teeth or wax rims are situated in maximum intercuspation or contact, when VDO is reduced. To recover that, according to a textbook, various methods can be used to determine the vertical dimension. Many researchers claim their methods are very good, but these are not very easy methods. So I use the speech or the appearance of the patient. This is my picture of my heyday. It is based on A1 equals A2. From the eyes to the lips is the same as ANS to the bottom of the jaw. This is the Willis method to measure VDO of edentulous patient. There are similar ways, and this is Mackey method, which is similar. When the VDO is lost, when there is a remaining teeth, we can use the existing denture or remaining natural teeth to measure that. If they are not available, wax rim or the appearance can be used to identify VDO. These tools can be used. I borrowed this material from my beloved Dr. Park. I want to introduce a case of intern Chung Ji-won at the Prosthodontal Department, Seoul National University Dental Hospital. This is very well-made case, so let me explain that. 68-year-old male patient. Various problems are seen here, especially the occlusal vertical dimension is pretty lowered. How to raise VDO? The prosthetic approach is very difficult. An intern made a presentation with this case, which is a very good case. The vertical dimension is measured based on the face. So we decided to raise 4 to 5 millimeters of VDO at the canine. Vertical dimensions at the canine are measured. Increasing VDO of canine by 4 millimeters is the treatment plan. According to the plan, occlusal rim was made and the stent was made. If you raise VDO TMJ trouble can be resulted. So we check whether that creates any problem. Based on that, wax up is done and the provisional is made and tried in the mouth of a patient. Here is the difference between the private practitioners and those in a university like an intern. The teeth need to be reduced all at the same time to fabricate the provisional. It requires a lot of efforts. It is not done in stages. The teeth need to be reduced at the same time. It requires a lot of time. So this is a more accurate approach. Based on the planned video, implants are placed. It is not that implants are placed first and video is adjusted. According to the set video, implants are placed using the OSSTEM's one guide. I lectured about the one guide to the prosthetist in the seminar last year, and implants are placed on the maxilla. Based on newly set video, bite registration is made. In provisional, the new one is made. Ultimately, final impression is taken. Definitive prosthesis was delivered. This process is authentic, described in a textbook, which is not an easy case. This is the post-op X-ray. It took a lot of time and very well done. This is not easy for a practitioner to follow. It required a lot of efforts. This is a case of Dr. Park Hee-ung, which is a little bit simpler for a private practitioner to follow. This is not a full increase of video. Existing prosthesis is used and resin buildup on natural teeth. In the textbook, it says video increase of 5 millimeters in anterior region can be done. With the prosthesis, the aesthetics of anteriors would be a problem. Therefore, for that purpose, video can be increased. This is using the resin buildup. This is a good summary of the case. That's why I'm introducing it to you. When attrition or wearing is severe, vertical dimension can be increased using composite resin. When posterior region is stabilized, the anterior region can also be stabilized. Prosthesis in the posterior region, the porcelain can be reduced and the resin can be built up with a certain thickness. This can be maintained. This is not something clinicians do often, but I observed the long-term outcome, which was pretty good. So intraorally, the resin built-up was made. The marks indicate the increase of the vertical dimension. The adjustment is made little by little in the mouth. This is more convenient than reducing all the teeth at the same time. About 3 millimeters of increase of video was achieved. Implants are placed and the video is increased. Final restoration. By referencing the implants, the vertical dimension is adjusted. That's why the buildup on the anteriors and premolars remain stable. So it was maintained for a long term, 4 to 5 years. We may think resin buildup is not strong enough to stand for a long time, but that was achieved due to the stable occlusion over the implants. It was completed pretty well. Clinicians can access this rather easily. I don't have photos, but I struggled to treat this patient, 80-year-old schoolmaster's case. Implants were placed on the maxilla, and prosthesis was done in the mandible, but the teeth had attrition. Anterior teeth are worn down due to vertical pressure. The roots of endocrown fractured, so they were extracted. So the vertical dimension became very low, so teeth could not be made in the anterior region. Ultimately, there was attrition in the anterior teeth. It's hard to chew and the gum can be damaged. So I decided to increase the video. Two implants are placed at number 6. The lower anteriors are worn down so much that they cannot be restored. The resin buildup is done only at premolars. Resin buildup at 4 and 5. Using the implants, the vertical dimension is slightly increased. If you compare these two cases, video is increased. This much of increase made the superintendent very happy. He can chew without hurting the gum. We need to study to increase video, and you can refer to the simple resin buildup. Going back to the case under discussion, if surgery is difficult, as the professor said, slight increase of vertical dimension can be done to place implants. If the systemic diseases are under control, number 1 and 2 can be extracted. The patient is 66 years old, but the teeth need to function for 20 more years. Therefore, more fundamental treatment can be done. Anteriors are extracted, and I don't like the prosthesis at the posterior, so the vertical dimension should be increased slightly. And the resin buildup at the lower anteriors, implants in the missing area. There's a systemic disease in this patient, but the vertical dimension needs to be raised. It's a large-scale treatment. Yes, this is a big treatment. May I ask some questions? Vertical dimension increase. In the first case, you used temporary provisional. How long do you need to do that for vertical dimension increase? We need to observe a TMJ for months to increase 3 or 4 millimeters in the anterior region. Unless the patient had a TMJ problem, I don't think we need to observe it that long. To be honest, the provisional prosthesis is not strong enough for proper chewing, so it cannot withstand for a long time. So I move on quickly. Rather than using the provisional, PFM or metal can be used. If that doesn't create any aesthetic problem, it's used for functioning and changed to aesthetic one. Checking TMJ with the provisional for months, I don't agree with that. To maintain that there should be residual teeth to have contact. Can the resin buildup stand? It's better than we expect. In the ortho process, to treat a crossbite, sometimes we raise the vertical dimension a little bit and move teeth. Sometimes it is raised partially with the resin buildup. For a short time, the resin buildup is okay. I asked the question if it is only. The resin buildup is covering the whole occlusion surface. Raising the vertical dimension is a challenging job because the whole teeth need to be worked on. For a private practitioner, it is difficult to reduce all the teeth at the same time unless you have a lab nearby. But the resin buildup can be easier to handle. Coming back to the case under discussion, if we assume to increase 3 or 4 millimeters, number 3, 23, and 34 and 34 would come in contact, and the buildup in the mandible can be made, but they can chew on only with that part. Temporary denture needs to be used. If that is used, maybe with that you need to determine the vertical dimension. What do you mean? If you use a temporary denture, using the temporary denture, the rest of the teeth will not come in contact on the left side, so we need to work on the prosthesis. The gingiva cuff of the prosthesis in the upper left is too low, so it needs to be worked on. The margin doesn't fit either. So you need to increase the vertical dimension? Yes. You didn't explain how long it takes. It goes with the prosthesis process. You don't wait. When you do resin buildup and implants are placed, which takes 3 or 4 months in the mandible, and you're talking about that timeline. Actually, it doesn't take 3 or 4 months. These days, I tested when the bone is good like that. When implants are placed, I load them at 6 weeks. It has to do with the surface. I do ISQ test. BA or SOI, advanced surface, can be used from SLA. So if initial stability is good, 4-week loading can be done too. So 6-week loading is done. I don't wait for stabilization of TMJ. I just go along with the prosthesis process. But sorry, I don't agree with you. 6-week loading. There are patient factors. 66 years old and systemic diseases are there, so isn't it a little bit dangerous for 6-week loading? The patient has systemic disease. I test every 2 weeks, provided the initial stability is gained. Every 2 weeks, I test. When initial stability is achieved, I don't experience problems. What about Dr. Kim Kyoung-won? 6-week loading. I don't really load them early. I'm conservative because I still have the habit working at university hospital. 6-week loading is too early. I wait for about 8 weeks. It's very similar. Yes, it's much earlier than before. Private practitioners talk about anytime loading. At the lower left, when 2 or 3 implants are placed together, I believe we can load them much earlier. In today's case discussion, we talked about how to treat a patient with collapsed vertical dimension and systemic diseases. I would like to thank the dentist who sent us very good case, and I would like to thank 3 doctors who gave us a lot of advices. This concludes the discussion. I am Dr. Jung Young-won. I'll see you next time. Thank you very much.